You're welcome.
Thank you very much, Brett. I appreciate that very generous introduction. Um, so yeah, my name is Dr. Eduardo Javier, and I am the program director of the new Addiction Medicine Fellowship Program here at Eisenhower Health. It is in consortium with University of California, Riverside and Hazelden Betty Ford Center. It's a one-year program wherein we train physicians that have special interests in addiction medicine in order to deliver an integrated and comprehensive care to all people affected by substance use disorder. So what do I mean by all people? It's not just the people who directly are afflicted with substance use disorder, but um, also their family members. Because as we know, addiction or substance use disorder is a disease of the family. And um, if we treat a patient with substance use disorder, we also treat the family. So so that's one of the goal of the fellowship, and also we would want to destigmatize addiction and to change the people's perspective regarding substance use. So oftentimes we see patients when we think of patients with substance use disorder, we think of them being in a rehab center or in jail or um, uh, in a residential treatment program. So with the goal of the addiction medicine fellowship is we want to meet these patients wherever we can. We want to see them in the emergency room, in our clinic, and also here in the hospital. They could be admitted for another condition, and if they needed addiction treatment here in inpatient acute care hospital, we'll be able to provide that for them. And the other objective of the fellowship is to be able to augment the quality of care delivered at our institutions by improving the linkage to care, right? So um, I'll be talking about substance use disorder in general. Um, Addiction is a very broad topic, and all the substance of abuse is a very broad topic as well. So I'm just going to be touching base on the general principles of what addiction is all about, what substance use disorder is all about, the common medications that we usually use for substance use disorder, and what are the recommendations for treatments for patients with substance use disorders. All right. So just for definition, addiction is a chronic relapsing illness. So it involves the brain reward system, and it induces alterations in this system caused by chronic drug use. So substance use disorder has no permanent cure, but there's treatment available. So the goal is to get these patients to treatment as soon as possible, wherever they may be, to deliver treatments and medication-assisted treatment to these patients to decrease mortality and morbidity, um, to decrease the rate of mortality, including death, in this particular group of patients. Um, since it is a relapsing and chronic disease, we should manage them with medications, behavioral therapies, and long-term care follow-ups. So treatment of addiction is a lifelong treatment. It's not just, after a couple of weeks in a rehab or um, a month or 90 days in residential. It should be lifelong, and it should be followed up long term. All right, substance use disorder, as I have said, is a chronic brain disease characterized by compulsive substance seeking and use despite harmful consequences. So it could be any substance. It could be um, substances that you take that you continue to use, or the patient continue to use despite harmful consequences. Um, so it's a chronic relapsing, and could be progressive if not treated properly. So it has the same relapse rate as congestive heart failure, diabetes mellitus, asthma, and hypertension. So just like any other of these chronic conditions, um, they have the same relapse rate. They have the same compliance rate. They have the same treatment response, but the thing with congestive heart failure, diabetes mellitus, hypertension, and asthma, we do not let them go or or discharge them from the clinic or from the hospital without giving them any medication. So it is just proper that we would prescribe medications to substance use disorder as well. So um, basically, it is about the relationship. What is the relationship of these patients to their substance use? So what is the relationship of the substance in terms of their day-to-day existence and day-to-day life, and how does substance use affect their their lives? So addiction or substance use disorder involves the brain reward system and alteration of the system caused by chronic drug use. So there are certain parts of the brain that are affected by substance use. We know more now about the neurobiology of addiction than we know about schizophrenia or depression or anxiety. So we know certain parts of the brain that are involved in whenever they get, you know, the euphoric high. What parts of the brain that are involved when they're having withdrawals? What part of the brain are involved when they're craving and having those thoughts of use? So we have just recently discovered this by, you know, the great work of Dr. Volkov from the NIH, and have identified these parts of the brain. So addiction or substance use disorder is a brain disease. So basically it involves the limbic system, which is the primitive system of the brain. This is part of the brain where it tells us what is essential in life, such as oxygen, water, sex, family, um, foods, all those things that involves in the perpetuation of the species, and also for survival. So what happens in the brain is that after taking these drugs for a long time, it tricks the brain or hijacks the brain, making it believe that the substance that they're using is essential to their existence. So if it's essential and if it's important for them to survive, and they think it is important for them to survive, they would do everything and anything in order for them to get those drugs, right? So it primarily affects the brain um, in the ventral tegmental area. So this, once they bind to the receptors in the ventral tegmental area, it sends signals to the nucleus accumbens. And this nucleus accumbens is a part of the brain that this is rich in dopamine, and the neurons here will secrete the dopamine, and then it will be perceived as a euphoria or feeling well, feeling good, a sense of, you know, well-being and wholeness. And this memory of feeling good will be deposited in or um, will be saved in the hippocampus, which is the memory part of the brain. And later on, they would remember these substances. That's why when they're having, you know, when they, for example, they go on the grocery store, they would pass on to the liquor store, for example, and that would remind them of their use, or they would remember the events when they first used. So because that memory is stored in the hippocampus. And the other part of the brain that is involved in addiction is the prefrontal cortex. So the prefrontal cortex is the executive function of the brain. This is the part of the brain that tells us what is wrong, what is right, and um, tells to use and not to use drugs. So they have found out that this part of the brain, the prefrontal cortex, um, is not functioning very well, or there's thinned out. So there's decreased number of neurons in the prefrontal cortex. That's why their decision-making capacity is impaired um, because of prolonged substance use. All right. So there's a DSM-5 criteria. The DSM-5 criteria is a diagnostic criteria for substance use disorder. So basically, when the patients come to us, um, we do the DSM-5 criteria and see how severe their addiction is or their substance use is. So usually, it's basically comprised of the four C's and four R's, and accompanied by withdrawals and tolerance. So what are the four C's? The four C's are compulsions to use. So there will be, you know, that's all they once they've thought of using, they're just going to be autopilot. They're just going to do whatever it takes to get their substance of choice. So compulsion to use, cravings, and that's all they think about all day. Continued use despite consequences, and loss of control. So they would be planning to drink one or two bottles. They ended up drinking the 12 pack or they only wanted to use for one day, they ended up using the whole month, and they would binge for the whole week or something like that. So there's loss of control, and they wanted to stop, but they couldn't and they would only stop and when their body couldn't take it anymore, or they haven't slept for several days, and they're just so exhausted and they couldn't take it anymore. And then the four R's would be risk of bodily harm. So they would continue to use despite having cirrhosis, having congestive heart failure, having hypertension, or um, um, bloodborne infections, HIV, hepatitis C. Despite of those, they would still continue to use. Um, they would continue to use despite relationship troubles. They've divorces, breakups, have burned their bridges with their family. Um, and also they would continue to use even if they fail to fulfill their roles, such as like absenteeism in their jobs, decrease performance in their jobs, their role as parents or friends, and um, or sons and daughters. So they fail to fulfill those roles and continue to use despite repeated attempts to cut back. So most people with substance use disorders, um, they think of stopping and quitting all day long and every day. I still have to meet somebody who uses and doesn't think of quitting every day. Also, all of them wanted to quit. It's just that the prefrontal cortex, as I've mentioned, is just so weak, and they um, cannot uh, overcome the compulsion to use. So that's why this prefrontal cortex is the target for behavioral therapies that I will later on discuss to you. All of these therapies are are geared toward rehabilitation or treatment of the prefrontal cortex. And then we have tolerance and withdrawal. Withdrawals are syndromes wherein the patient would develop withdrawal symptoms if they abruptly stop or decrease the dose of the drugs that they use. And then tolerance means um, the same dose does not exhibit the same effects, or they needed higher dose to achieve the initial effect. All right. So if they fulfill 2 to 3 of these, they would be mild, 4 to 5 would be moderate, and more than six would be severe. So it's very important for us to classify the severity of addiction, because we want to know how are we going to deliver this treatment to these patients. Some patients, if they're mild, they could be managed as outpatient. If they're moderate to severe, they probably need to be removed from their environment in which they're used, and be admitted to a residential treatment center. All right. So right. So why are we concerned about all the substance use um, happening around us? So we all have heard about the opioid epidemic that has been going on for almost over a decade now. Um, it is initially brought on by um, prescription pain pills, and later on when prescription pain pills when physicians are decreasing the number of prescriptions, the patients resorted to taking heroin. And recently, for about 3 to 4 years now, there's been an up, surge of people using fentanyl. Fentanyl is more potent than heroin and prescription pills, so it provides a higher euphoria. It provides a higher effect. So as I've mentioned, tolerance develops in throughout time. So there would be sometimes there would be progression from pain pills to heroin to fentanyl. And when they've gone to fentanyl, it would be very difficult for them to quit without treatment. So there are 72,000 deaths every year for opiates, and majority of this nowadays are because of synthetic narcotics, and synthetic narcotics such as fentanyl. And most of these fentanyl now, they don't just come as purely fentanyl, but some of them are being incorporated to heroin, are being laced into Xanax, and also into methamphetamine. That's why you can also see most of the deaths that happen with stimulants or methamphetamine. Some of these were laced by fentanyl. All right, so 72,000 of people died in 2018. Um, According to CDC, more than 95,000 people die from excessive alcohol use in the United States each year. These are all because of complications of alcohol use. Um, All right. So who? Not everybody will develop substance use disorder. Not everybody will develop will become addicts. So who are what are the risk factors and who are prone to developing substance use? So there are environmental factors, personal factors, drug factors, psychiatric factors, and um, adverse childhood experiences. For the environmental factors, we have the community, the family, peer, and school environment. Environmental factors. So for personal factors, it is hereditary, 50 to 60%. Is hereditary. Unfortunately, we still have not identified a single gene. It's a cluster of genes. When they studied the genetic makeups of patients with substance use disorders, and temperament and psychology. So patients with high impulsivity, hyperactivity, and novelty seeking, especially the adolescents, um, um, and patients that use before less than age of 18 are higher risk of developing substance use disorder later on in their life, because again, the prefrontal cortex is not fully developed. Um, and then we have the drug factors as well. So the addiction potential of the drugs, the route, and the rapidity of onset with which these drugs are being taken. For example, IV drugs are more potent than oral, and inhaled or smoked drugs are more potent than IV. So the most potent form of drug route is through inhalation. All right. And then psychiatric diagnosis. So people that are diagnosed with anxiety, depression, and other mood disorders they have a high propensity of developing substance use disorders, because of untreated psychiatric disorders, and they self-medicate. Um, they self-medicate, and so they use these substances. And if they're unguided and not regulated and monitored, they could potentially develop substance use disorders later on. And and then we have the adverse childhood experience. Adverse childhood experience are traumatic and stressful events in a child's life, which could be abuse or neglect, um, family history of substance use in the family. And so they found out that in children that had adverse childhood events, there's a neurocognitive disruption in the development of their coping mechanisms to stressful and traumatic events could be impaired. And so these coping mechanisms, they would take it into their adult lives, and so they have maladaptive form of coping mechanisms. So patients with kids or adolescents that have adverse childhood experiences, they found out that they start substance use early when their brain is not fully developed. The higher incidence of picking up smoking at an early age. So it's very important that we protect our children, because sometimes it's a risk factor for them to develop substance use disorder later on in life. Aside from all these risk factors, there are also protective factors. The examples of protective factors are having a role model and parental discussion of the risk of drug use. Having open conversation with your kids is very important, and then engaging them in other activities such as sports and committees and groups. All right. So those are the protective factors. So once they continue to use chronically, it becomes a long-term, and that happens in their brain. And if they stop using, they would feel the withdrawal symptoms, and they would continue to use because they don't want to feel these withdrawal symptoms. And some people would also continue to use because they want to seek the remembered initial feeling, and also to self-soothe their negative emotional state. So some people use because they want to get high. Some people use because they don't want to feel the withdrawal symptoms. So there's a both negative and positive reinforcement involved in the continuation and establishment of addiction. So right. So there are several screening tests that we use when patients present to our clinic in the primary care, for example. But the most simplest screening test that we use, we just ask them, how many times in the past year have you had 5 or more drinks in one occasion? That's for men. And for women, how many times in the past year have you had 4 or more drinks in one occasion? So if you answered yes, or um, one episode in this question, we would go on further asking you questions regarding um, your substance use. And so we would go to the DSM-5 criteria. Remember the 4 R's and the 3 C's, and we would see if they fall into the category. And then for other substances, for the opioids, opioid prescriptions and cannabis, we would ask them, how many times in the past year have you used an illegal drug or used a prescription medication for non-medical reasons? So if they say yes to this, there's a high chance that they could be having substance use disorder. So we would investigate further. All right. So let's go now for the treatment. So there's the first part of the treatment is withdrawal management or detoxifications we all have heard of. That's just the first part, and that's just gradually and safely getting them off their medications, because withdrawal symptoms sometimes can be very, very uh, very dangerous, especially with alcohol and benzodiazepines such as Xanax, Ativan, Librium, and Valium, as well as alcohol. So there are other withdrawal symptoms as well for opiates and cannabis and stimulants. But I just wanted to just give you an example or an illustration and what happens to the brain during alcohol and benzodiazepine withdrawals. So our brain usually always is designed to achieve equilibrium and homeostasis. So that's why there's a balance between GABA and glutamate. GABA is an inhibitory neurotransmitter, and glutamate is an excitatory neurotransmitter. So there's always a balance. All right. So when we take alcohol is a GABA receptor agonist. So there would be an increase in GABA. So what happens to the brain? The brain wanted to achieve equilibrium. So in time, it increases the glutamate so that you will achieve equilibrium doing so. So what happens is that if you stop alcohol, if you stop taking the alcohol, there would be predominance of the glutamate. So glutamate is an excitatory neurotransmitter. That's why if it's predominance of glutamate, what happens to the brain is that you will feel anxious, you will feel tremors, you have sweats, you high blood pressure, your heart rate is going to go up. And if it's so severe, some people would have seizures and some people would have personality change. They will have confusion and delirium, which we call DTs. Or delirium tremens. All right. So how do we treat them? We treat them by giving them an equivalent medication called benzodiazepines. We usually use Librium or Valium to achieve the equilibrium pharmacologically, and then gradually taper them off this medication. And so the brain can also gradually achieve homeostasis, and that's the detox process. So usually it lasts for about a few days, depending on the heaviness of the use. The whole detox process can sometimes last several weeks if the heaviness of the use is severe. All right. So we use different medications for opiate withdrawal symptoms, as well as benzodiazepines and methamphetamines. All right. So that's the first part. The first part is just withdrawal management. That is not the whole treatment. And the second part is, there are other medications that we can use after the detox process for maintenance medications. So that these patients will take these medications to maintain. This is the medication that I'll be talking about. Remember, I told you about that patients with congestive heart failure, diabetes mellitus, they're giving insulin, they're giving medication for the congestive heart failure, for blood pressure medications, as well as for asthma. They have inhalers to control the symptoms. If they stop taking these medications, they will have a relapse of congestive heart failure. Their blood pressure will shoot up, the blood sugar will shoot up. So it's the same thing. It's the same thing with substance use disorder. If they stop taking these medications, they will have resumption or relapse or recurrence of symptoms. And what is the symptom? It's drug use. All right. So for alcohol use disorders, we use some of the evidence-based medications that we use are naltrexone, acamprosate, disulfiram, and topiramate. So what is naltrexone? Naltrexone is an opioid agonist. So we found out that some some percentage of people would they would when they drink they would have this sense of euphoria when they drink, or the buzz that they feel, whenever they have that drink. So we found out that it stimulates the mu receptors in the brain. So naltrexone is a mu receptor antagonist. So it antagonizes that effect on the brain of the alcohol. So when the patient drinks alcohol, they don't feel that urge. They don't feel that high or euphoria of using alcohol. So it decreases their craving and decrease the number of drinks when they drink. All right, so that's naltrexone. Acamprosate is also an anti-craving medication. It regulates the GABA and the glutamate receptors in the brain. The sulfram is, and it's aversive medication. So when the patient takes the sulfram and they drink alcohol, they get sick. So this is what we call also as ad abuse. They would develop symptoms like vomiting, nausea, generalized feeling, just the feeling sick, anxiety, increased blood pressure. Some people will have chest pain and palpitations because of drinking alcohol with disulfiram. And topiramate is an anti-seizure medication. It is also one of the most effective medication for cravings. However, it has some side effects. That's why not a lot of people wanted to take risk of taking this medication, but it's one of the more effective medication for alcohol use disorder. For opioid use disorder, what we usually use is methadone. I hope everybody has heard of methadone. We have the methadone clinic here in Palm Springs. We send patients there for maintenance therapy. The other medication is buprenorphine. The difference between methadone and buprenorphine is that the methadone, initially they had to go to the methadone clinic every day, and they have to be dosed there every day. With buprenorphine, we can induct them outside of the methadone clinic, and we can do this in the clinic, and we can give them medications to control their symptoms. So these are all opioid agonists, meaning to say they're analogs of opiates. And so when they take these medications, it controls their craving, it controls their withdrawal symptoms. They're able to fulfill their roles. They're able to get to maintain their jobs. They stop stealing. They stop lying. So all the addictive behaviors when they take these medications, methadone, buprenorphine, goes away. So so it decreases HIV transmission, hepatitis C transmission. It decreases criminality. It decreases relapse and overdose death from opioid use. So methadone and buprenorphine are beneficial in this regard. The other medication is naltrexone. Again, I've mentioned naltrexone is an opioid agonist. So it blocks the receptor of opioids so that when patients take heroin or fentanyl, it doesn't affect them. It doesn't affect the mu receptor, so they don't feel the euphoria. So the patients would say, "Why am I using this? Why do I keep on using heroin when I can't I can't feel the euphoria anymore?" So it can be given orally or deep intramuscular injection every month. For tobacco use disorder, we use varenicline, bupropion, and NRT means nicotine replacement therapy. So did you know that we only have discovered nicotine in 1990? Nicotine is only discovered as the the addicting substance in cigarettes and tobacco in the 1990s. Before then, nobody knows why people continue to smoke. So we have identified the receptors as well. So varenicline is an alpha-1 beta-2 receptor antagonist. So it binds to the receptor of nicotine so that when patients smoke, they don't feel the effect of nicotine. Bupropion is an antidepressant. They found out in the VA that when they have given the veterans with bupropion or Wellbutrin or Zyban, they found out that they have decreased smoking. So they don't know what is the mechanism, but it was approved by FDA for smoking cessation. And then NRT is nicotine replacement therapy in the form of a gum, a patch, a lozenge, a nasal spray, or an inhaler. So we can provide nicotine whenever they have the urge to smoke. All right. So cocaine, there's an off-label, slightly evidence-based treatment with topiramate and naltrexone. Methamphetamine, there's also some evidence for mirtazapine, Wellbutrin, as well as naltrexone as well. All right. So these are some of the pharmacological medications that we use. For cannabis, I failed to put it in here. We can give gabapentin for cannabis withdrawals and cravings as well. And then aside from pharmacological therapy, there are psychosocial and behavioral therapy, which I will be discussing next, and then recovery and support groups. Okay. Um, all right. So aside from medication assisted therapy, the other part of treatment is behavioral treatment, so psychosocial treatment. So we there are several treatment modalities that we employ. So when you go to your therapist, um, some of them would do motivational interview, which is enhancing motivation to change. Motivational interview is a type of treatment wherein we increase their motivation to change by letting them talk, because we found out that patients that um, are willing to change if they talk about change more. So we evoke the discrepancy and evoke change from them. We don't tell them this is what you should do, this is what you should do, because most of the time they just don't follow anyway. So we wanted to evoke that motivation for them to change from within and from themselves. So it's um, tested across short interventions of 1 to 4 sessions, even with sessions 15 minutes or less. All right, so that's motivational interview. And then the other ones are to improve skills of managing illness. So example of which is a cognitive behavioral therapy, wherein skills were taught and rehearsed together with the therapist. They're taught to do refusal skills, decisional delay, recognize tolerance and counteract painful feelings, talk through cravings, and foster healthy resources and reinforcement. So again, these behavioral treatment is directed to improve the prefrontal cortex or the executive function of the brain. So CBT is delivered for 8 to 12 weeks. It's usually role played. Patients are given homework and practice, and then we do functional analysis. We found out that CBT has a sleeper effect. It's long after 12 weeks, that it still has an ongoing effect and benefit. All right, so contingency management, it establishes a well-defined incentive or sanctions based on a well-defined and accessible target behavior. So contingency management usually works for stimulant use disorder for patients with methamphetamine use, as well as cocaine use disorders. So what are the incentives that we give them? We give them gift certificates, a verbal praise sometimes, and or draw from a lottery pool. So we give them incentives if they have a negative, if they come to the clinic with a negative drug screen, they have attended their groups, they have gone to therapy, and also if they have attended self-help groups such as AA or Smart Recovery. All right, and then if they fail to do um, their their responsibilities, they would give them sanctions, such as stricter electronic monitoring, writing assignments, and sometimes community services. All right, so we've heard of peer pressure. Peer pressure um, could also give us some negative effects, but also can be used for its positive effect as well. So if we see our friends, if we see some people that we know going to therapy, going to treatment, sometimes we get to be pressured to do better as well. So peer pressure could be used in that way. We also involve some family, wherein we teach them how to deliver positive and negative reinforcement, and as well as setting boundaries with family members with substance use disorder. And then therapeutic community, wherein the therapy is in the community. The goal is to global change in behavior. And then we have the 12 steps programs. All right. So those are the basic examples of the treatments that we recommend and that we usually do in patients with substance use disorders. So in 2016, there are 21 million people that have substance use disorders. Only 18% received addiction treatment. So there's a huge gap of the delivery of treatment and care for our patients with substance use. So we're very happy to have developed this program wherein we have established an outpatient clinic wherein we can deliver some medication assisted therapy to bridge that gap. All right. And then we have social support and recovery group. We have the AA and 12-step meetings, self-management and recovery training, which is the smart recovery. Some people will have some, Buddhist lineage or leanings. We give them resources to go to refuge recovery. And there's also mindfulness-based relapse prevention therapy. All right. Sometimes the goal for the patient is not complete abstinence, which sometimes it's difficult for them to complete abstinence is difficult to achieve, and so there are several advices that we can help them to provide them just to limit the harm of their substance use, such as wearing a helmet and wearing a seatbelt, drinking within the recommended limits. The recommended limits for male is less than four, less than four in a day, and less than 14 in a week. For women, it's less than 3 drinks and less than 7 drinks three drinks in a day and 7 drinks in a week, as well as the same thing with people more than 65 years old. So we found out that studies have shown that if they are within the drinking limits, there's decreased incidence of complications of alcohol use. And also, we advise them to take a taxi, Uber, designate a driver. Sometimes, smoking 3 cigarettes a day instead of a pack is better than, smoking the whole pack. And then we would refer them to syringe exchange program to reduce hepatitis C and HIV transmission. And we always provide them with naloxone Narcan to reduce death from opioid overdose. All right, so this is what happens to the brain. This is a functional MRI that they have done, the study of patients with substance use. So in the bottom pictures are the normal examples of the brain. The red ones I want you to focus on are the dopamine receptors in the brain. So we have in normal individuals, there's normal numbers of dopamine receptors. When patients that have substance use disorders, for example, alcohol, obesity, and cocaine, there's decrease or downregulation of dopamine receptors in the brain. All right. So this is what recovery looks like. So there's a decrease in the dopamine receptors, right? After 14 months of abstinence in patients with methamphetamine use disorders, there is gradual improvement in the number of dopamine receptors. So there's an anatomic proof that patients do recover if they just stay on treatment. Because again, as I've said, the treatment for addiction is long term, and it gives me hope that these patients, and reassuring the patient that they could get better, because sometimes they get demoralized that they're not getting better and they keep on relapsing, and you just encourage them to think, hey, studies have shown that if you just stick it out, that you're going to get better. All right. So lastly, I would want to talk about stigma. Stigma is an attribute to behavior or condition that is socially discrediting. So there are different types of stigma. Stigma from within. Stigma from within the patient. They blame themselves and they feel hopeless. They get so demoralized, especially when they relapse, and they would just continue on relapsing because they feel like they couldn't get out of their situation. And the other source of stigma would be from the recovery community, medications versus abstinence. Some patients that are on Suboxone and methadone, some of their peers would consider them not to be clean. So there's that stigma that if you are in maintenance therapy, you're not in full recovery, which is wrong, because we know that addiction is a disease of the brain, and it needs to be medicated, to be treated properly. And studies have shown, and evidence-based medicine have shown that all the addictive behaviors disappear if they are on medication-assisted therapy. Sometimes stigma from clinicians. Not everybody will have training with addiction or substance use. Um, we have, I know for a fact that there are certain clinicians that, they're just easy to discredit patients with substance use disorder, and it's difficult for them to treat because, sometimes they said, they may think that it's a moral failing, or it's a choice, and they're suffering, that they deserve the suffering that they are going through. And then stigma from the outside. Again, some people would think that it's a choice rather than a disease. So the impact of stigma is that it erodes confidence that substance use disorder is a valid and treatable health condition. It acts as a barrier to jobs, housing, and relationships. It deters public from wanting to pay for treatment, allows insurers to restrict coverage, stop people from seeking help. And because it's the number one, that's the number one reason why people don't want to start treatment, because they don't want to be um, labeled as or stigmatized as substance use or addicts. And then it impacts clinical care and treatment decisions. All right. So words matter. We try to avoid using the words that are stigmatizing and that carries a negative tone, and we would want to change them into a more neutral and more acceptable term. For example, patients that are addict, we want to address them as persons with opioid substance use disorder. That's why I've throughout this lecture, I've constantly tried to correct myself, saying that, patients with substance use disorder. For patients that are user, we call them, person who uses drugs, not a junkie or an abuser. Patients with drug habit, we would call them opioid substance use disorder. And patients that has misuse or harmful use are engaged in irregular and risky, unhealthy, and heavy use. For drug screen, or for urine drug screen, we don't call them clean drug screen or dirty drug screen. We call them as it is. It's a testing negative for substance use or positive for substance use. And then if they're on replacement therapy, we call them treatment or medication assisted therapy or medication for addiction. Relapse, we would want to change it to resumed using or recurrence of symptoms. And babies born with addicted mother, or babies born with an opioid dependency, or babies born with neonatal abstinence syndrome. So yeah, so we would try to change the words that we use with substance use disorders. All right. So yeah, so that ends my lecture. Yeah, just remember to be kind. For everyone you meet is fighting a hard battle. And yeah, having substance use disorders, it's a daily battle for our patients. Thank you very much.
So, Dr. Javier, we have a couple of questions that came in the chat before we open it up to others. The first one was, can you talk about why you mentioned methamphetamine in your slide about detox?
Say it again.
Can you talk about why you mentioned methamphetamine in your slide about detox?
Detox. Yeah. So so usually with patients with methamphetamine use disorder, they would come in. They would come in. For example, they had just recently used. So part of the treatment is making sure that they are safe. So most of them had used continuously for several days, and they'll be dehydrated. They'll be having muscle cramps. Some of them will be hallucinating. Some of them will be having personality changes, or having increased anxiety. Some of them are maybe even violent. So we put them in a very safe place and make sure that we treat them appropriately. So part of the detox is also making sure that they're safe physically and medically, that they some of them have not eaten for several days. So we make sure that they're provided with adequate nutrients. So that's part of the detox process as well. There's no medication that we use for methamphetamine, specifically for their withdrawals. We just treat them symptomatically. If they get too violent, we give them something to calm them down. Most of the medication that we use for methamphetamine is supportive treatment and management.
Great. As a follow-up to that, what kind of electronic monitoring? Only for alcohol?
Yes, for now, yes. We, the bracelets and, the ankle stuff that we, that that they use for monitoring. Yeah, those are the only ones that I know of.
And another, is there anywhere in the valley that that someone can go through alcohol withdrawal without going into treatment program?
Yes. Our clinic we are located in Cathedral City. There's we have established an outpatient clinic at the beginning of this fellowship program in July. So we've been there for about 5 months now. We take patients there and evaluate patients, and if their setting is appropriate for outpatient detox, we would we would give them medications to do a home detox protocol. Yeah, so our clinic is an avenue for that.
Great. Is that clinic located in the Target Center?
Correct. Yes.
At the residency clinic?
Correct, in the residency clinic.
Thank you. So are there other questions from people? Feel free to unmute yourself and ask a question. Or use the chat feature.
Can you hear me?
Yes.
Yeah.
Where can we meet with you? Do you have an office or a contact number?
Yes, we do. So yeah, so you can call our clinic is you can call clinic 760-773-4300.
Okay. And you also do you take does Medicare and supplemental insurance work with this program?
Yes. We take most commercial insurances, yes.
Through Medicare also?
Correct, yes.
Okay, great. So just call that number and try to get an appointment with you?
Correct, yes.
Right. Thank you, doctor.
Yeah, and you can search us through Eisenhower Health website as well.
Okay.
Yeah.
Great, thank you.
Brett, do you want to put that number into the chat so people have it readily available?
Yes, Doctor, can you tell me that number again?
Yes, it's 760-773-4300.
There was another question too. What is the name of your clinic?
It's Eisenhower Health, Eisenhower Health Addiction Clinic.
Other questions from anyone? Is there an age? I guess one thing that does come up, is there an age where there's somebody say 60, they've been using it for 40 years and they're in their 60s. What's the likelihood? I mean, should they be looking at, if they have a desire now at this age, to go into detox at some time?
Yeah, I mean, yeah, as I've mentioned, addiction it depends on the relationship with their medication and continued use despite consequences. And if they feel that, that it has gotten away with their lives or the quality of their lives, their substance use had affected their day-to-day lives, they can come and have themselves evaluated by us, and depending on their substance, we can hopefully help them and also direct them to proper care and linkage to care should it be necessary. So we don't have an age limit. So far we had treated I'm primarily an internal medicine physician, so I treat adults from 18 to the older adults, and we even had patients that that are under 80s that wanted to stop drinking or benzodiazepine or other substances.
I know this is a very general question, but are there any estimates on how long it takes an individual before an individual has their life under control after diagnosis?
After treatment, have their lives under control. So that's a very difficult question to answer, because again, addiction is or substance use disorder is a chronic and relapsing disease. So it's characterized by a lot of relapses is the norm. if the patients are on maintenance therapy, for example, if they're on methadone or Suboxone, or they have finished detox with alcohol and they're on anti-craving medications, and if after detox, and if they continue to participate in their treatment and go to treatment, go to their therapists, counselors, address their psychiatric needs. I would say after a couple of weeks that they have established a new routine, and if they have a stick out to that schedule, there's a good chance that they would be able to maintain sobriety.
Doctor, I run a continuing legal education group in Chicago, and I also do drug screening for courts when the parents may or may not have substance abuse issues. I'm seeing a lot of polysubstance. Do you have any comments about that?
Yes. So yeah, it's very common. Yes, you're absolutely right about that. That's the thing is, it's the availability of these medications and the manner of which, how easy it is to procure these medications. It's surprising, to be honest with you, that it's just available around the corner. It's just a text away. It's just an internet message away. So because of the availability of these medications, so most of these patients that sometimes they're around other people as well that had used other substances. So, they would be seeking other because of the tolerance that, the patients develop. As I've mentioned, the same dose will not give them the same high. So they have to go on increasing their dose or augmenting that with other substances to have, to achieve another high or another sensation or another feeling. So it's very, very common for patients to combine substances. For example, some people would combine heroin with methamphetamine so that it kind of balances out the effect. And also people would also combine methamphetamine and benzodiazepine so that when they get high with methamphetamine, so that for them to come down properly, they would take benzos so that they can sleep. There's also people who are combining alcohol with cocaine, so that cocaine is a stimulant and alcohol is a depressant, and so they would use cocaine so that they can drink more. So yeah,
we're seeing a lot of combinations of alcohol, amphetamines. They can't even measure the amount of marijuana.
Right.
And the idea is, how do you develop a trier so that you can, what do you try and get them off of first?
Okay. Yeah. So we want to try to get them off everything. We don't prioritize first of what's the most damaging, for example. So among the drugs of abuse, the most damaging is alcohol. To the body, the most damaging, and then followed by heroin, fentanyl, and then methamphetamine, and the benzodiazepines, right? So, but we would want them to stop altogether at once, and that's why the detox process is very important for us to do, and to make sure that they are guided properly during this process, which is going to be difficult. Some people would say, "Oh, I'm just gonna quit alcohol and not smoking," So studies have shown that one substance can trigger the use of another substance. So that's why we would want them to quit altogether, because they try to associate smoking pot with drinking, so it triggers them to drink. So it kind of just a vicious cycle if we let one substance let them use another and stop with the other ones.
Thank you.
Yeah.
Did Scott have a question that didn't get answered? I'm not sure. I read that in the chat, so I wasn't sure. Scott, did you have a question?
No, he dropped.
Oh, he dropped out? Okay.
Yeah, we had answered his, I think. But Colleen, or I know Nancy, I know Colleen both unmuted. I don't know if you have anything further you'd like to ask.
I was wondering about specific to alcohol. One of the treatments that was supposed to be effective was the naltrexone.
Yeah.
How expensive and how is that? What are the side effects and how long do people usually have to take it? I mean, is that something then you pretty much take the rest of your life?
Yeah, so first question, how expensive it is. It's usually covered by Medicare. So I have a patient that that is on naltrexone oral, and with coupons, we also give them coupons. With coupons and everything, it costs them about $25 for a 30-day supply. So it's taken once a day. And then, so that's oral naltrexone. There's another naltrexone, which is Vivitrol, which is the IM once a month injection. So, and that's usually the one that is that has a cost. So we have to do prior authorization and tell the pharmacy to to supply and cover it for the insurance to cover it. So for the duration, again, addiction is a chronic disease. So the recommendation is for them to be maintained on this medication for as long as they can tolerate, because it decreases relapse rate, it decreases complications of their substance use. And then what are the side effects of these medications? So there's one of the side effects is it affects the liver as well. It's metabolized in the liver. So we would want to, sometimes we monitor their liver enzymes every 3 months. It's very rare though, that it causes that, because it blocks the mu receptors. We warn them that if they, for example, they get engaged in an accident, or they have to go for a procedure, that they have to tell their surgeon or their doctors that they're taking this medication before giving them a pain pill, because it blocks the effect of the pain medications. So those are the side effects and the warnings for naltrexone for alcohol use disorder. It's one of the most effective medications, and we would want everybody to give it a chance.
Thank you.
All right. Well, I think we are at 6:30. Unless there's a final question that someone would like to ask, I don't know, Candace, if you have any other thoughts on anything.
Mr. Klein, we can't hear you. You muted yourself.
Yeah, we're both in the same room, so you'll hear reverb. So you might hear me twice now, but that's why I was trying to talk loudly. I was going to say we are at 6:30. So in case there was someone that had a final question they'd like to ask, or Candace, if you had anything you wanted to tone in. And as we posted, the video will be posted by tomorrow on the LGBT Center website under Eisenhower Health Lectures, and you'll be able to find it there. You'll find it eventually on the Eisenhower website. We have to do some editing and some other things on our side. Thankfully, the center doesn't have those requirements that we do.
And excuse me, I'm not familiar with the center. Can somebody tell me what that is?
Oh, absolutely. Candace.
It's the LGBTQ Community Center of the Desert. So we're a community center, and we have a behavioral health clinic also. So we do a myriad of programming, support groups. Of course, they're all Zoom right now, but when people could come in the building, we would have them in the building. So, and so our website is www.thecentercv.org, and you'll be able to access the video there. And also you could browse that and see what we're all about. We're going to be opening, our behavioral health clinic is open now, but we're expanding it. And after the first of the year, that expansion onto the second floor of our building will be open for the behavioral health clinic also, and an intern program that goes on there.
And Mr. Klein, if I wanted to talk to you further about a program that I need information on, how would I get to you?
Yes, you can reach me at B as in Brett Klein, Klein, at eisenhowerhealth.org.
Okay, And the other thing is, do you distinguish between programs you do for young people? I know about the Children's Center, but that's a different focus. But I'm talking about young people versus individuals who might be 65 or older. Do you have different programming?
Are we talking to Dr. Javier, Eisenhower Health? Who are you?
You mean programming in the sense of lectures and educational kind of community?
Yes.
Oh, okay, yeah. So most of our, because we're here in the Coachella Valley and a heavy component of, we tend to skew, especially with our lectures and community outreach, to more or less more adult, 50 plus kind of individuals.
Okay.
We do, when we're in person, with the LGBT Center, they have a much more robust age bracket. So we've had community in-person kind of things where we get a younger audience attending. But for the most part, most of our community kind of education are geared to senior centers, adults, in very few cases we're doing children stuff unless it is hands in-person kind of stuff at our schools. And then we bring someone in to work directly with the facilities themselves.
Yeah, I'm trying to look for a program that would work with the parents themselves so they understand the importance of their returning to a sober state.
Yeah, nothing we currently offer that I know of, but it's reach out to me and then let's talk a little further about what that might be. And maybe there's someone here that might be able to talk to you a little more about that.
That would be great. Thank you so much.
You bet.
And you are at the resident center, or are you?
I am not. No, so I'm in administration. So I'm not a physician or a clinician. I am in marketing and public relations here at Eisenhower on the main campus.
Very good. Well, I will reach out to you. Thank you so much,
please
everybody.
Do.
This has been really good.
All right.
Thank you.
Thank you, everyone. And thank you, Dr. Javier.
Thank you so much.
Doctor.
And
Very well done.
See you in a week or so for the next lecture. Next week, next Wednesday.
Bye-bye.
Thank you so much.